Good evening, everyone. So, after a rather long break of about 3 weeks, we'll be continuing the series on bullous disorders, and we're starting this series uh, discussing the genetic bullous disorders, starting with epidermolysis bullosa group of inherited disorders. This video would be about EB simplex, the epidermolysis bullosa simplex complex of disorders, and sequentially we'll be discussing the junctional and the dystrophic type, along with Kimler syndrome, and a separate video on the diagnosis and management of children with epidermolysis bullosa. Okay, so usually EB simplex or EB as a whole topic comes as a short note or rather a long note in your exams. I doubt that you would get a long case or a short case of a EB child in your exams, at least at the residency level. But they do form a significant proportion of patients in our inpatient wards, and you need to know the theoretical aspects are important as far as vivas are concerned, as far as understanding the basic concept of the disease is concerned, and the management is important as far as managing these babies are concerned. Now, epidermolysis bullosa, the children are known as butterfly babies because the skin is very delicate like a butterfly. Okay, so this is one good viva question or a quiz question that can come. So they're known as butterfly babies. And what essentially is the problem with epidermolysis bullosa group of disorders is that the glue that holds the layer of epidermis adhered to or stuck to the dermis, the layer is deficient. Okay. Now, depending on the level of that deficiency, if it's at the basal level of the basal keratinocytes, or if it's at the just above the dermis, we have different type of segregation in the form of EB simplex, EB junctional, or a dystrophic EB. So as we go downwards, as we go from the keratin filaments 514 at the basal level of the basal keratinocytes, and as we go downwards to lamina lucida, lamina densa, and then we go towards the papillodermis, all the proteins that we had studied previously in the last three videos on basal membrane zone, if those proteins are deficient or genetically mutated, the adhesion is not there. The cells are not properly attached to the underlying structures. And because of that, even trivial trauma is going to lead to separation. And those separation will lead to a lot of blistering, a lot of erosions. And depending on the type of mutation, for example, dominant mutations are less severe. The recessive one will be more severe, or depending upon the protein which is affected. For example, keratin 514 mutations are somewhat less severe as compared to mutations in plectin or plakophilin or exophilin. So these are much more severe mutations. The issue with epidermolysis bullosa simplex, as far as theory is concerned, that we have a lot of subtypes because the problem is in classifying epidermolysis bullosa. So normally it is classified as simplex, junctional, and dystrophic on the level of split. And simplex is further classified into generalized severe, generalized intermediate, and localized form, and other subtypes. Now, this classification is based on clinical appearance of symptoms, the clinical distribution of blisters, and also the eventual outcome of the baby. Okay, but with further studies in molecular basis of pathogenesis of disease and the level of split and genetic basis of the mutations in individual disorders, this kind of segregation might not be helpful. So right now, the stress is more on the level of genetic mutation rather than dividing into generalized, severe, intermediate, or localized. Okay, we must know what exactly genetic mutation is there in the patient so that we can look at the level of split, and that after that we can know about the severity and also extracutaneous manifestation. Whatever organ has that particular mutated gene will be affected, and then we can easily segregate into different parts. But for the level of this lecture, as far as residency is concerned, we'll discuss epidermolysis bullosa in three major parts, and the fourth other part. The major part is generalized severe, then generalized intermediate, then localized, and all the other subtypes as a fourth part. Okay. In the end of this video, I'll tell you a good mnemonic with which you can easily remember the other subtypes of EB simplex. So this week we'll discuss only EB simplex, and then in the subsequent weeks, we'll be discussing the other types of epidermolysis bullosa. Now, without much further ado, we'll begin this week's video on EB simplex. So this is the definition of EB simplex. So this you have to write. And these are inherited group of disorders characterized by a common feature of blistering in response to mild trauma. So you have to write mild trauma. The trauma is trivial. Okay. The hallmark of EB, the group of disorders, are that there is skin and mucosa fragility and trauma-induced painful blisters. Okay, so these blisters are not spontaneous; they are a result of trauma. Now, remember that you have different layers of epidermis and dermis, and they are closely stuck together with the glue in between. And this glue are made by different proteins that we have studied in the last 3 weeks while we were studying based on the brain zone. If any of these proteins are deficient or mutated, this adhesion is lost. So the layers can then easily separate and form blisters. Okay. So if you can see this, the layers are closely attached to each other and they will not separate normally. But if the protein is mutated, they will separate and this will cause blistering in response to trivial trauma. The differentiating factors between different subtypes of EB simplex is based on the distribution of the involvement, the depth of the blister, the associated extracutaneous involvement, and the severity of the blistering process and how the blister heals. Okay, as we go deeper, and we will study more about it when we will be discussing junctional and dystrophic, that as we go deeper, the level of split is deeper, more severe is the disease, more severe is the healing of the blistering process, more is scarring, more milia. Okay, that we have discussed while we were discussing BMZ. Now, EB simplex has more or less a normal lifespan to debilitating morbidity to mortality. So it's a huge spectrum of outcome. The child might be normally okay for its entire life, or it could have significant morbidity and mortality. Okay, let's move forward. Now these are just some names which you can remember, so that multiple times when in quizzes they are asked, you can answer them. So EB simplex or epidermolysis group of disorders were labeled by Cogner as epidermolysis bullosa hereditaria. Okay. Hellepoe classified them as scarring and non-scarring forms of EB simplex, and Hurlitz was the first one to give epidermolysis bullosa letalis, okay, which we now know as junctional EB. And in the honor of Hurlitz, we call it as the Hurlitz type of EB, Hurlitz EB, or Hurlitz junctional epidermolysis bullosa. Okay, and if we have a Hurlitz type, we also have a non-Hurlitz type, but we'll learn about them next week while we'll be discussing junctional EB. Now, this is the same slide that we had discussed 3 weeks back when we were discussing basal membrane zone. And here are the structures from top to bottom. We have basal keratinocytes in which you have keratin 5 and keratin 14 predominantly, which will form desmosomes, and desmosomes are in between adjacent cells. Below that, we have lamina lucida and lamina densa. So this is lamina lucida, this is lamina densa. In lamina lucida, you will have majorly integrins and BP2 along with hemidesmosomes. So this here is hemidesmosome, and below that you have integrins and BP2. In lamina densa, you will have majorly laminins, this cross-shaped laminins, nitrogen, typhocollagen, heparin sulfate, perlecan. These are all molecules that we have discussed when we were discussing the part 3, I believe, the video on basal membrane zone. And below that, in papillary dermis, we have anchoring filaments, anchoring fibrils and collagen 7. Okay, if you want a detailed discussion, then look at the previous 3 videos where we were discussing basal membrane zone in complete detail, so that you can easily understand the normal architecture, the normal structures, and then you come back to EB group of disorders so that you can better understand the defect. So pathogenesis of EB, there is defect of attachment of basal keratinocytes to the underlying dermis. So this we are talking about EB simplex. Okay, in EB simplex you have a basal cell, and the basal cell is attached by hemidesmosomes. Now this hemidesmosomes is attached inside the cell by various keratin filaments. So these are keratin filaments. What would happen if this keratin filaments is mutated? So there is no keratin filaments now. If there is no keratin filament, there will be blistering. So here you can see that this basal cell is properly attached because the keratin filaments are there. In this cell, there is no keratin filament, so it will get uprooted from the lower structures. Okay, so here you have the normal epidermis and here you have epidermis from a EBS child. Okay, so there can be multiple mutations, but the most common mutation is in keratin 5 and 14. So most common mutation is seen in keratin 5 and keratin 14 mutation. In EB simplex, the most superior aspect of basal membrane zone or at the level of hemidesmosome, there is problem. So that's what we have explained, that at the basal level of basal keratinocytes, where keratin filaments attach to hemidesmosomes, that area is broken. Because of mutations of keratin 5 and 14, the cell is not able to properly attach to underlying structures. So this diagram I've taken from Bologna. The reference is Bologna 4th edition, page 540. And here it shows the normal intact skin where you have basal keratinocytes. These are the keratin filaments which are attached to hemidesmosomes. Okay. So in disorders like EBS, here we see the localized and the generalized intermediate variety. The keratin filaments are deficient. They are deficient, or a better word instead of deficient would be mutated. So there is mutation, an autosomal dominant mutation in the keratin filaments. Okay, autosomal dominant. Predominantly, there are recessive forms of UV simplex, and these are the distal cavity. In the generalized severe one, you also have keratin filaments aggregates. Let me write here. Keratin filament aggregates. And this aggregates cause further problem in the transport of materials inside the cell and to one cell to another. And that leads to a lot of extracutaneous manifestations, a lot of pigmentary anomalies, okay, a lot of dysfunction in the cell, and thereby increasing the severity. Okay, so this is one difference between localized EBS and intermediate EBS as compared to severe forms of EBS. That in severe form of EBS, you will have keratin filament aggregates, clumped keratin filaments. Okay, let's move forward. So, in molecular basis of pathology, it's very interesting, or it's very easy to understand if you know the basic pathology of basal membrane zone. If you want to go in detail, Rooks 10th edition is very good book if you want to know about the genetic basis. It's not much; it's 3-4 pages only, but it's very good reference to learn about the genetic basis and all the proteins which are involved in EBS. Most commonly, you have keratin 5 and 14 mutation. Most commonly, okay. Hemidesmosomes, and this we are talking about hemidesmosomes like the inner hemidesmosomal plaque, outer hemidesmosomal plaque, integrins, other base membrane zone structures. These are all normal. The problem lies in keratin 5 and 14. Most disorders are dominant. Okay, most of the disorders are dominant. Some are recessive with variable severity. If they're recessive, they'll be more severe as compared to dominant one. Helix boundary domains are conserved regions in which mutations have more severity. Now, we have not undergone a video on keratinization, but let's just say that keratins have this kind of a rolling pin structure. We'll go in details when we'll be discussing keratinization. But there are certain regions inside the keratin molecule, the keratin protein, which are highly conserved. And by conserved means that they don't change much in humans. And if there is a mutation in these conserved regions, the severity would be more because these regions are important. All the other regions which are in between, they're non-conserved regions, and any mutation in non-conserved region may or may not be severe because they are not exactly important for the aggregation of keratin filaments. Okay, so if the conserved regions have a mutation in them, there will be more severity. Am I clear on that? If there are other protein molecule mutations like plectin mutations, plectin mutation also has muscle dystrophy, where there is problem in the aggregation of muscle fibers because plectin protein is also utilized in sarcomeres. Okay, so that is why you have extracutaneous manifestations. So if you know the protein and if you know the location of protein, you can easily remember the extracutaneous manifestations. Okay, so plectin is also present in sarcomere, and because of their presence in sarcomere, there is muscle dystrophy. Now, clinical findings are different in different subtypes of EBS, and they are based on the ultrastructural level of split. So nowadays, the diagnostic gold standard is electron microscopy. But most of the diagnosis that we make in EBS is only clinical. There is also a clinical EB matrix in which you can put the symptoms of the patient and you will get the probability or the most probable diagnosis. Okay, and that is by Vamsi et al. If you want, just go and search about it and you will learn about it. If you want a separate video on how to use the matrix, let me know. I can make a short video on how to use the matrix. It's a good clinical tool. Okay, you just put the symptoms and it gives the most probable subtype of EB. Okay. Now look at these three boxes. The green box means that Fitzpatrick 9th edition, page 1003, are there. The clinical pictures of EBS are present in this page because YouTube doesn't allow me to put pictures of children who are diseased. So I will not be putting them here. But I've mentioned the pages of textbooks in which the pictures are there. You just have to go and open them at this page number and look at the pictures. The blue one is Bologna 4th edition 541 page and red one is Rooks 10th edition 69.8. Okay, just go to this page and you can have the clinical pictures available. The clinical findings, or in a generally speaking manner, the clinical findings in EB simplex is that the disease group is characterized by intraepidermal blistering. Remember, it is happening at the lower level of basal keratinocytes. So the split is happening in the epidermis. So it's intraepidermal blistering, and most often is associated with keratin gene mutations. There are other gene mutations, other protein mutations, but the most common EBS is keratin 5 and 14 mutations. So as we have mentioned, there are four distinct clinical types, not distinct, there can be overlaps, but there are four major subtypes. The generalized severe one, also known as Dowling-Meara, generalized intermediate one, known as Cogner's, localized one, which is known as Weber-Cockayne, but these are older terms, okay? If you read Rooks 10th edition, these terms are not that much used. Now it has mentioned autosomal dominance, generalized severe EBS, autosomal recessive, generalized severe EBS. That's how Rooks 10th edition mentions. And slowly, I believe this classification system will be changed because there's a lot of misclassifications, a lot of difficulty in segregating them into separate watertight compartments. That is not there. There are overlap of clinical findings. The fourth type has all the other subtypes like EBS Ogna type, EBS with muscular dystrophy, EBS with mottled pigmentation, etc. So all of them form the fourth type. So let's discuss each one of them in detail. We have the generalized severe EBS, also known as Dowling-Meara. These are the older terms. It is also known as herpetiform variant of EBS because in herpetiform variant, why it is known as herpetiform? Because there's so much blistering. Look at the diagram. So on the trunk there can be grouped vesicles. So this looks like herpetiform. So that is why generalized severe EBS is also known as herpetiform EBS. It is autosomal dominant in inheritance, however 30% can be sporadic. There is blistering at birth in a generalized distribution and it is the most severe subtype as the name suggests. So here look at the diagram, the blistering is generalized. Okay, and as the name suggests, it is generalized and severe EBS. Clear? Oral mucosa is extensively involved. Okay, extensively involved. They can be plus minus milia. Now remember, in simplex subtypes, in EBS simplex subtype, the split is very superficial. So it may or may not have milia, but as we go down at the level of split, the probability of milia rises. There can be nail involvement, initially starting with shedding and later nail dystrophy. Now this point is important. Palmoplantar hyperkeratosis. Palmoplantar hyperkeratosis is mentioned, and as the time passes, it can become severe in the form of confluent keratoderma, which can be painful and can cause contractures. This is an important point in EBS, that you have significant palmoplantar hyperkeratosis, and at later stages, it can become confluent keratoderma, which can be painful as well as can have contractures. The mucosal involvement is significant, enough to cause esophageal erosions, pyloric atresia, and upper respiratory tract involvement. There's also association of growth retardation. Okay, So this is EBS type, generalized severe, also known as Dowling-Meara. The generalized intermediate is EBS, also known as Koebner EBS or just Koebner's disease. It is also autosomal dominant inherited. Now, all the three subtypes, generalized severe, generalized intermediate, and localized, are autosomal dominant inherited. Okay. So, in the Koebner subtype, it is essentially same as generalized severe, just the level of severity is less. Okay. So, there's generalized blistering at birth or early infancy, which can become worse in warm weather. Most involvement is at the level of extremities. So most of the involvement is at the level of extremities. Why? Because they only come into contact with the environment. So mostly the extremities are involved. So look at this diagram. Mostly the extremities are involved. Healing happens with post-inflammatory hypopigmentation, occasional atrophy of the scars, about in 60% of cases, or melia can be seen in about 15% of the cases. The palmoplantar hyperkeratosis, which was characteristic of EBS generalized severe one, is plus minus in intermediate one. Okay. In late stages, there can be thickened soles. Oral mucosa will have mild erosions. So can you see that the features are more or less same, but it's like generalized severe features, but toned down to about 10% or something. Okay. So it's a milder form of generalized severe. That's why it is known as generalized intermediate. Okay. Let's move forward. Now, this is localized EBS, also known as Weber-Cockayne disease. It's a mild form. So, we have gone from severe, intermediate, and now the mild form. There is blistering on feet. Other areas can be involved in about 10% of the cases. So, there's blistering here at the level of feet, and this blistering spares the sides of the toes. So, this is very characteristic. This blistering spares the sides of the toes. This is the most common form of EBS. Okay, this is the most common form of EB simplex. So this is a good viva or a quiz question. Okay, most common form of EBS. The blistering happens in infancy or childhood, can present later also. There is hyperhidrosis of palms and soles. So remember in the first one, severe one, there is palmoplantar hyperkeratosis. In the second one, there can be plus minus hyperkeratosis. In the localized one, there's hyperhidrosis of the palms and soles, which are common. Healing happens with pH, but no melia or atrophy because it's a mild disease. Most commonly involved are hands and feet, and least common involved is the scalp. So it's at the level of extremities again. That is why it is localized to extremities. It is known as localized EBS. Oral erosions are rare but can occur in about 25% of the cases. The nail involvement is mild and localized. That means occasionally one or two nails can be involved. So now you can understand as we move from generalized severe to generalized intermediate to localized, the level of severity and the distribution extent is also decreasing. So after that, we'll start the other subtypes of EBS, and they are in significant number. But at the end of the video, I'll show you a good mnemonic to remember all of them as of now. Of course, with further research, new and new subtypes might be added. We'll change our mnemonic then. So the first subtype is Epidermolysis bullosa simplex Ogna type. Okay. So Ogna has onset in infancy. There is seasonal blistering on summer on acral areas and they heal without scarring. There is onychogryphosis of great toenails. So this is important. Okay. Rooks 10th edition classifies this as a variant of generalized intermediate EBS or autosomal dominant inherited EBS or intermediate EBS. So this is a new, not a new term, but this is a new way of classification in Rooks 10th edition. So the way to remember Ogna is OGNA. O is onychogryphosis. Onychogryphosis of the great toenails. G is in Hindi Garmi. That means in summer season you have blistering. Okay. N is no scarring. There is no scarring in the lesion. And A is acral areas are involved. So now you can easily remember what do we see in Ogna type. Okay. Let's move forward. EBS with muscular dystrophy. We have already mentioned that there is plectin mutation, and plectin is present in sarcomeres. So the mutation causes blistering in the epidermis and dystrophy of the muscle cells. It's a rare disorder and autosomal recessive in inheritance. Now, I've mentioned that the three major subtypes, the generalized severe, generalized intermediate, and the localized one, are autosomal dominant. Now, these subsequent subtypes, the fourth group, can have autosomal dominant or recessive disorders. Just remember that if there is increased severity of disease, most likely it is because of autosomal recessive inheritance. So there is generalized blistering near birth, plus progressive muscular dystrophy. So anything that you have to remember with EBS with muscular dystrophy is that is because of plectin mutation, and it's a rare form of EBS. Clear? Let's move forward. EBS with mottled pigmentation. Now this picture is on Rooks 10th edition 69.9, in this you have blistering and there is mottled hyperpigmentation of trunk and proximal extremities. So this is mottling, presence of hypo and hyperpigmented areas. Okay, so this kind of a variegate presentation or a variable pigmented presentation. So this is mottling. So mottled hyperpigmentation on the trunk and proximal extremities. It is autosomal dominant inherited. Remember the muscular dystrophy one was autosomal recessive. There is pigmentary alterations and blistering which improve with increasing age. So now can you do you realize that this subtype is improving with age? It is less severe and that is why it is autosomal dominant. It's a way to remember. If it's more severe, then it's autosomal recessive. Okay? Mild atrophy and nail dystrophy. Now, why does EBS with mottled hyperpigmentation or EBS with mottled pigmentation exist? The theory says that because of keratin filament mutations, keratin filaments also have other function of transporting vesicles, and the cells are not able to transport melanosomes effectively, and that leads to mottled pigmentation. Okay, let's move forward. EBS superficialis. So, as the name suggests, there is subcorneal separation. Okay, and let me just make a diagram. So here you have the superficial layer and here you have the basal layer. Here the separation is much more superficial at the level of subcorneum. It's an uncommon form of EBS. Subcorneal separation happens and there's more of erosion and crusting rather than intact bullae, and it heals with pH. You can say that it is somewhat analogous to pemphigus foliaceus because you have a subcorneal separation in the epidermis. There can be nail involvement, atrophic scarring, or milia can be plus minus because the separation is very, very superficial. EBS with migratory circinate erythema. It's again an uncommon form of EBS, autosomal dominant. There is just a few blisters with itching with a migratory circinate or circular erythema and post-inflammatory hyperpigmentation. So this unique and this uncommon subtype of EBS is autosomal dominant inherited. And since it is autosomal dominant inherited, it is less severe. All it has is migratory circinate erythema, which heals with PIH along with itching. Okay, so you can just say that it's a EBS coupled with a little bit of inflammatory disorder. EBS with cardiomyopathy. It's a newest form. Also, there is some contention about it, but people regarded it as a newer or a newest addition to the group of EBS subtypes. It was added in 2016. It is autosomal dominant in inheritance. It is EBS with cardiac arrhythmias and cardiomyopathy. Blistering happens on lower legs, trunk, and upper limbs, which improves with age. So now you can remember it is autosomal dominant inherited, so it improves with age. The lesions heal quickly with subtle atrophic scarring. So there is less atrophic scarring. Okay. Nail defects, melia, and oral ulceration are common. Now here the mutation lies in the Kelch-like family member 24. So remember cardiomyopathy, Kelch-like family member 24. Okay. And this mutation leads to abnormal autoubiquitination of keratin 14 and decreased keratin 14. Now, what is ubiquitination? Ubiquitination, in the process of ubiquitination, what happens is any protein which is useless for the cell is marked for destruction. So the cell marks that I don't need this protein, destroy this. This marking is known as ubiquitination. Okay. And because the mutation in Kelch-like family member 24, the keratin 14 is wrongly marked to get destroyed. And because of that, the functional keratin 14 decreases, leading to EBS phenotype. Okay. So this is how EBS with cardiomyopathy happens. The same molecule is present in cardiac and heart also. So you have cardiac arrhythmias and cardiomyopathy. EBS with nephropathy, it's autosomal recessive inherited with biallelic mutations in CD151. Now CD151 encodes for tetraspanin. We already discussed tetraspanin in part 3 of basement membrane zone. Go back and see that video why tetraspanin is important. There is widespread blistering, especially on the shins. There is poikiloderma, loss of teeth, alopecia, and esophageal stricture, and nephropathy with proteinuria. So a good way to remember is that in EBS with nephropathy, you have mutation in tetraspanin. That's one point that you would like to know. Tetraspanin 24 mutation. Tetraspanin mutation. And there is poikiloderma and nephropathy. So that this leads to a good quiz question or a viva question, that what is the mutation in EBS with nephropathy? It is tetraspanin 24. Or tetraspanin. We just mentioned tetraspanin. Now, EBS with Plakophilin Deficiency. I know there are so many subtypes, it becomes difficult to remember. But don't worry, at the end of the video, you'll see a mnemonic to remember all the names. And then you can just remember 2 or 3 points about each subtypes. So, EBS with Plakophilin Deficiency is known as ectodermal dysplasia, skin fragility syndrome. There is suprabasal epidermal separation. There is generalized erosions at birth, alopecia, palmoplantar keratoderma, painful fissures, nail dystrophy, failure to thrive, cheilitis, hypohidrosis, pruritus, all of these features are seen in Plakophilin deficiency. Just remember, for the sake of quizzing or any MCQs, that EBS with Plakophilin deficiency is also known as ectodermal dysplasia, skin fragility syndrome. Okay, just remember these 2 points. In EBS with BP230 deficiency. Now remember, BP is the bullous pemphigoid antigen 230. Okay, let me ask you a question. Mention that in the comments if it is BPAG1 or if it is BPAG2. Let's see how much you remember from the previous 3 videos. Okay, it's a rare form of EBS in which there's mutation in the DSTE gene. DSTE gene just encodes for dystrophin. Okay, so if there's a mutation in the dystrophin gene, it leads to the truncation of dystrophin. That means if you have the entire protein as dystrophin, with the mutation, a tip or a part of it is lost, and that leads to a truncated dystrophin protein. And because this BP230 is an essential component, which, okay, let me just say everything again, don't worry. Let's remove everything. So, just look at here. Here is the lower boundary or the lower membrane of the basal cell. And here you have the hemidesmosomal outer and inner plaque. And here you have BP230. So what happens if this tip is lost? Because the tip is lost, the connection between the basal cell and the lower structures are lost, leading to separation. This is what happens in EBS with BP230 deficiency or EBS with BP230 mutation. This type of mutation is reported in Kuwaiti or Iranian families. That leads to localized blistering, often the feet, because you need trauma for blister to occur. Traumatic blistering, so feet are most commonly involved. There is no significant mucosal or other extracutaneous involvement. There is no scarring. So it's a benign form. Okay. And since the only upper part is lost, the mucosal involvement is not severe. There is no scarring because the split is still superficial. It's not deep. Okay. And there is no extracutaneous involvement. EBS with Exophilin-5 deficiency. Just bear with me. I know it this video becomes boring 10 minutes ago because there are a lot of subtypes of EBS. All you have to do is remember the names and 2 points with each. Okay, just go through this video at 1.5x the speed. Something will stick in your mind and it will become very, very easy to remember. EBS with Exophilin-5 deficiency is rare. It's autosomal recessive in inheritance. Mutation in EXPH5. EXPH is exophilin. There's trauma-induced crusting of fragile blisters and vesicles which heal with crusting. So one thing to remember about exophilin deficiency is that there is significant crusting. Crusting we have heard before also in EBS superficialis, the one which we could easily say as pemphigus foliaceus analogy. So you have more of crusting, not more of bulla, more of crusting. But in exophilin-5 deficiency, you have blisters, you have vesicles, but they are very fragile. They get ruptured easily, and then there is significant crusting. Okay, the disease is mild, and there is no extracutaneous involvement. Remission or improvement during childhood is characteristic. Now, this is a very important point. It's a point which is so strongly said in Rooks and in Fitzpatrick that improvement during childhood is characteristic of EBS with exophilin-5 deficiency. Let's move forward. Acral peeling syndrome. And I promise you, this is the last subtype. Bear with me. Acral peeling syndrome is the last subtype. The mutation is in transglutaminase 5. Okay, transglutaminase is a very important enzyme in the process of keratinization. Maybe in the future, when we'll discuss keratinization, I'll discuss the use of the role of transglutaminase in the process of keratinization. And in acral peeling syndrome, the mutation is in transglutaminase 5. And because of that, the process of keratinization is not proper and there is superficial and painless skin peeling. Mostly hands and feet are involved because again you need trauma. Humidity, heat, water exposure exacerbates like any other form of EBS. Humidity, moisture is going to exacerbate. The separation is between stratum granulosum and stratum corneum. Now this is the important point. So if you want to remember 2 points in acral peeling syndrome, just remember that the mutation is in transglutaminase 5 and the separation is between stratum granulosum and stratum corneum. So if the separation is between stratum corneum and stratum granulosum, this superficial split will be there and there will be less pain or painless skin peeling. Clear? Mostly on the acral side. That is why it's known as acral. That means hand and feet are involved. Peeling, there will be painless peeling and syndrome. Clear? So as I had said, these are the last subtype, and I'll give you a mnemonic to remember them. Don't worry. So in the classical forms of EB, this is a diagram which I've taken from Rooks 10th edition, page 69.2. In EB simplex, the split is very superficial, going till the basal keratinocytes. In the junctional EB, it's in the lamina lucida and lamina densa. In dystrophic EB, it is lamina densa and then sublamina densa. In Kindler EB or Kindler syndrome, it is from the basal cells to entire all the way till sublamina densa. In the other skin fragility disorders, the peeling skin syndrome, like acral peeling skin syndrome, the defect is at the level of stratum corneum and stratum granulosum. In hyperkeratosis with skin fragility, you have in the upper layers of epidermis. In erosive disorders, see, for erosions to occur, you need to have bulla. And bulla will happen if the split is lower down in the epidermis. So in erosive disorders, majority of the splits is in the lower side. And in connective tissue disorder with skin fragility, you have major problems in the sublamina densa. So this is a good diagram. If you want to know more about the genetic basis, read the newest Rook edition. It's somewhat good reference for this, and then you can see this diagram and make more sense of it. And this diagram is taken from Bologna. It's a good image or a good graph to see and remember why the names of simplex and why as we go forward from simplex to junctional to dystrophic, the level of scarring melia increases. So the yellow one, so let's see the yellow one, wait a minute. Yeah, the yellow one is none. Okay, it's none. So as we move from EBS, the simplex one to junctional to dystrophic, to recessive dystrophic EB, there is more of findings. So the none will go back to 0. Okay, that means some cases of EBS can have no clinical findings. As we move forward, we see the scarring increases. The blue one is scarring, it increases. The orange one is nail dystrophy, that also increases as we move from simplex. Other disorders like all three findings, melia, nail dystrophy, scarring increases. Okay, and this one is melia. So as we move from simplex to junctional to dystrophic, dominant dystrophic to recessive dystrophic, the severity of melia, nail dystrophy, and scarring keeps on increasing. Okay, so if you see a patient with a severe forms of these three features, you can be pretty much sure that you're dealing with junctional or dystrophic forms. So this is approach to laboratory diagnosis of epidermolysis bullosa. In today's video, we'll just discuss this very shortly. And in subsequent videos, we'll keep on coming back to this flowchart from Bologna so that we are able to easily understand. So if you have a patient, you should go for immunofluorescence antigen mapping or a transmission electron microscopy. Now, I know that in India, these access to these disorders are not, these modalities of investigation is not there. This is just a flowchart in Bologna. And if I was here, I would add here clinical examination first. So if you're making a flowchart like this, add a box of clinical examination first. And in clinical examination, you should write if there's nail dystrophy, scarring, media, go for junctional or dystrophic. If it is not there, then go for simplex. If it is locally involved in localized simplex. If it is generalized involvement, look at mild, look at severe. If it is generalized severe, go for generalized severe. If it is generalized mild, go for generalized intermediate. So I will add somewhat of this kind of flowchart before the box of immunofluorescence mapping is there. Okay, but since Bologna has made it, let's discuss. So the preferred sites is the upper inner arm, just above the elbow, like just here, or a non-acral blister prone area. So what happens, the way of taking a biopsy in an EBS child is you take a pencil eraser and just rotate 180 degree in each direction about 3 to 10 times. So like this pencil, you just attach it and just rotate it. And because of this rotation, there will just be a little erythema. And from that erythema, you take a 4 mm punch biopsy and then send it for investigations. Okay. Additionally, you can do next generation sequencing panel with the known EBCs, do a whole exome sequencing, and you might find the exact mutation. So scan the sample in Michel's media, just look for DIF, not exactly DIF, just look for immunofluorescence. Okay. Determine the plane of cleavage, that where the split is present. Okay. So depending on the level of split, you can easily see where the split is there. After you have determined the plane of cleavage, look for the abnormal expression of basement membrane proteins. So depending on what protein is defective, you have the disorder. So this is more like a developed country approach to EBS, while in a developing country like India, in reality, we have to keep the clinical acumen or the clinical examination foremost before we go for this kind of hi-fi investigation. But for the sake of exams, we must know this kind of hi-fi examination so that we can write them down. And at the end, there's always, in all genetic disorders, you have to write genetic analysis to look for gene mutation or protein mutation. This you have to mention at the end. So try to make a flowchart if you're writing a long answer question or a long note on approach to EBS. Now these are the different subtypes which we have just gone through: generalized, severe, intermediate, localized. These are the major subtypes. And then you have the minor subtypes or the rarer subtypes. And now we'll be discussing how to remember these subtypes, or at least the names of these subtypes. So remember that most common mutation in EBS is in keratin 5 and 14. Keratin 5 and 14 can have both kind of dominant, recessive, and even sporadic. If it is dominant, it is less severe, so generalized intermediate, localized variation. If it's recessive, then it can lead to more severe forms of EBS. And if it is sporadic, then it can be severe or mild, depending on what is the level of severity of mutation. If it's in the conserved region, then more severe. If it's in the non-conserved region, then less severe. Okay. Lectin can also have both dominant or recessive. So these are the gene mutations which can present as both dominant and recessive. Kelch-like member 24, which is seen in EBS with cardiomyopathy, is transmitted as dominant. Clear? Let me write cardiomyopathy properly. EBS with cardiomyopathy is dominantly transmitted. Mutations in Exophilin-5 BP230, which is the DSTE gene, and CD151, which encodes for tetraspanin, are all recessively transmitted. So this thing you can just have a look at this slide. I'll remove all the markers. So just look at this slide that keratin 5 and 14 have both forms of inheritance, while Kelch will have dominant, and Exophilin, BP230 and CD151 will have recessive inheritance. So you can take a screenshot of this. Let's move forward. So finally, I think this is one of the most important aspects of the video. Mnemonic for uncommon EBS subtypes. Uncommon means group 4. Okay, group 4. So first group is generalized severe, then generalized intermediate, then localized, and then you have the fourth group which has all the other subtypes. And if you want to remember the names of subtypes, the mnemonic is code name SPD. Okay, so SPD was a very popular series known as Power Rangers, one of my favorites. I used to watch them regularly. Okay. So just remember code name SPD. So this is the mnemonic. So let's learn what are these names. So for C, we have EBS with cardiomyopathy, Kelch mutation. For O, we have Ogna, onychographosis, Garmi, seasonal summer exacerbation, no scarring, acral areas involved. D is dystrophy, muscular dystrophy, lectin mutation. E is erythema, circinate, marginal circinate erythema. N is EBS with nephropathy. Okay, you have nephropathy with proteinuria. Okay. A is acral peeling syndrome, transglutaminase 5 deficiency. M is mottled pigmentation, autosomal dominant inherited. Pigmentation improves with age. E is exophilin mutation. S is superficialis. P is plakophilin mutation. And D is dystrophin mutation, which is seen in BP230 mutation. Clear? So just remember the mnemonic. I'll repeat again. It's code name SPD. C for cardiomyopathy, O for Ogna, D for dystrophy, muscular dystrophy, E for erythema, N for nephropathy, A for acral peeling syndrome, M for mottled pigmentation, E for exophilin mutation. In SPD, S for superficialis, P for plakophilin mutation, D for dystrophin mutation, BP230. Clear? So just take a screenshot of this slide and you can easily remember the names and just say 2 to 3 points of each subtype and you can master the group 4 of EB Simplex. So in this video, I have combined these 3 sources majorly. I have looked at different articles, but only 1 or 2 lines have been taken. Majorly, I've covered the chapter 69 of Rooks 10th edition, which deals with Epidermolysis bullosa, chapter 32 in Bologna, chapter 60 in Fitzpatrick 9th edition. So if you want to read more in details regarding textbooks, but I would suggest you go through this video, which has information from all the 3 textbooks, and then go for individual papers, individual articles to know more about different aspects of EBS. Okay. Now, an important announcement before we finish the video, that the National Academy of Medical Sciences is conducting its first ever NAMS psychiatry quiz, and in this you will have major questions from psychiatry, but you will have a minor questions from general question, that is anything under the sun, and these questions were contributed by me, and there are a lot of different multiple different quiz coordinators here you can find who have contributed different aspects or different questions to this quiz. The last date of registration is 15th of May. and if they are still open, if you're viewing this video before 15th of May, the cash prizes are awesome. Okay, in my time, you won't even get 10% of this. So I think it's a significant enough cash prize if you plan to give the quiz and maybe get qualified for the finals. At least even if you qualify, you will get something for your efforts. The registration is absolutely free. Just scan this QR code and the eligibility criteria is written. So go get registered for this quiz, and I shall see you in the finals if you manage to cross the threshold. So with that, we finished this week's lecture of EB Simplex. I hope you have find it to be less boring, somewhat clarifying the concepts. The major part of this video was on different subtypes and how to remember them, and why you have different kind of manifestations. And because of this different kind of manifestations, it becomes very difficult to group EBS. And that is the problem with the current classification of EBS. And that is why I think it's going to change in the future. So if you have any comments, any doubts, any suggestions, any queries, mention them in the comment section below. I have not been replying to comments for the past 2-3 weeks because I've been busy, but I'll start replying from today onwards. You will see that I have started replying to the comments. If you have any suggestion for newer topics, mention them in the comment section. I do keep a list of suggestions in which I keep on adding topics, and whenever I find interest in a certain topic, I'll start doing a series. I'll meet you next week again with EB Junctional, and I'm just going to say goodbye with this photo of one of my favorite book in front of St. Peter's Basilica. So this is one of the good photos. There were a lot of good photos. This is not even the best one, but this is one of the good photos in St. Peter's Square from my recent visit in Rome. So beautiful country, difficult to go to because of visa issues, but if you can, just go visit. And I shall see you next week with dystrophic epidermolysis bullosa. Bye. Enjoy your weekend.